Thank you, Anne, and thank you, Mary, for a great introduction, and I think she has laid the foundation for future discussions in this topic. And I have to drink a lot of water because it's very, very dry in Europe. So my topic is obviously something very close to my heart. It's something I've worked on for more than 10 years. So I don't know whether I can convince you, but certainly, with the results of the aspirate trial, at least that is one step forward than backwards. And I hope we are not going to keep going backwards and we'll move forward from now. In terms of how we developed the first trimester algorithm, I think it all started about 12 years ago when we thought, okay, this is a serious condition. We need to find ways of predicting this condition. And we went for a very pragmatic approach. Obviously, at that time, the most effective method of screening in pregnancy is for Down syndrome. And we took the approach that we used to develop Down syndrome screening to determine the prior risk, which is based on the maternal age, to define the disease, obviously we know is because of trisomy 21, and then based on that, we identify and quantify biomarkers such as NT, free BCG, PAPA, and POGF, and then propose models of screening and intervention. Knowing that pre-eclampsia is a lot more complex than trisomy 21. We are certain that we cannot find one test that could predict this condition. And so we adopted the same approach that we have for Down syndrome. So determine the prior risk based on prior history, based on maternal risk factors, and we now believe that preeclampsia is because of impaired placentation, and based on that, we did obviously an extensive search for biomarkers, more than 50 biomarkers we have evaluated, and then at that point, what we had in terms of intervention was perhaps aspirin could be preventative of preeclampsia. So our thinking is that we should propose a first trimester combined screening model followed by aspirin prophylaxis. So you have already heard from the previous speakers about the several professional bodies' recommendations, which are essentially based on maternal risk factors. I think the use of maternal risk factors is very important. What I ask of you is to utilize the information intelligently, not to treat continuous variable as dichotomized variable. I'm today 40, yesterday I was 39. I was low risk yesterday, I'm high risk today. I think we need to move away from that thinking. So we have established the prior risk model, which essentially built the basis of our combined screening model. So two things that we did. First, we used a multivariate regression analysis to incorporate risk factors that we know and into this algorithm. The most important of using this technique is that we can treat continuous variables as such. Age, height, weight, and so forth. And we can also utilize maternal risk factors to increase as well as reduce the risk of a woman, not just to keep increasing the risk of a woman, so we can reduce the risk of a woman. So this is the first step we took. The second step that we did was to utilize a concept of David Wright, a competing risk model, assuming that if all pregnant women were to remain pregnant indefinitely, every pregnant woman will develop preeclampsia. But whether she develops preeclampsia or not depends on whether delivery happens before preeclampsia develops or after. And this is the same concept for prostate cancer. So if all men were to remain alive indefinitely, then they will all develop prostate cancer. So this mathematical approach has led us into creating these curves that you can see. So the curve on the top represents an average risk woman. Through this, we have estimated that an average risk woman would deliver at around 55 weeks gestation, but of course, in reality, she delivers before 42 weeks, and her risk is basically represented by the area under the curve. It's about 2 to 3%. If a woman has risk factors that could allow her to be reduced in terms of the risk, then we will shift her curve to the right. So now her area under the curve is substantially reduced. And if she has any of these risk factors, as you can see with the forest plots, with the squiggy plot on the left, we can then increase her risk, and her curve is shifted to the left, and now her risk is substantially increased. This is a mathematical approach that I cannot do myself, but certainly I think it's important for us to understand the concept that has led to the development of the base background risk model, and the risk calculator will be able to take care of the risk calculation. Then, as I said, we've done a lot of searches, more than 50 biomarkers that we have evaluated. There are essentially 4 predictors that have remained predictive for preeclampsia: 2 biophysical and 2 biochemical markers. The first biophysical marker is the measurement of blood pressure. And indeed, this was my thesis back in 2005. It was very boring. I mean, I'm a doctor. I should not be focusing on measurement of blood pressure. But what Kipros challenged me was, so, blood pressure, how should we measure it? I said, well, we have blood pressure machines. Put the cuff on, press the button. You know what he said? But we have 2 arms. So which arm should we use? I said, I'm not sure. Whichever way the desk is being set up in the clinic, then I'll use my right arm, or whichever way the desk is set up so that I can use the left arm. So essentially, we had no consensus. And I did a search so that to find out, do we have a standardized methodology in the measurement of blood pressure, which is the most important thing that we do in antenatal care. Every time we see a woman, we measure blood pressure, do we have a method of measurement? In fact, I could not find any recommendation back in 2005. Things are a little bit different now, okay? So I had to go for some non-pregnant guidelines. I found 2, one from America, one from Australia. The American one was very crazy. I had to measure blood pressure in both arms until 2 consecutive measurements reached stability, whereby systolic and diastolic blood pressure were within 5 millimeters mercury. So I went for the Australian. They were a little bit, less straight. So 10 millimeters mercury for systolic and 6 millimeters mercury for diastolic. So less tight. So in the end, I went for the Australian recommendation. And in women, honestly, I had to measure up to 10 times to get down to that stability. So after putting 20,000 women through this horrible experience, I narrowed down a protocol. So these are the recommendations. So based on 20,000 pregnant women having been through, the Australian protocol, we now recommend that blood pressure should be measured by validated automated devices calibrated at regular intervals. What do I mean validated? Most of the automated devices out in the market, they underestimate blood pressure in pregnancy and preeclampsia. So we must make sure we use the right one. And women should be rested, okay? They're always rushed into the clinic and they need to be rested. We need to make sure the arms are supported at the level of the heart. Otherwise, we will underestimate and overestimate the blood pressure. We need to use the right size cuff and we need to take measurements from both arms simultaneously twice. So altogether, I get 2 measurements from each arm. And they take an average of the 4. So the second biomarker that we have been advocating for is the measurement of uterine artery Doppler. And this is the recommendation. We need to put the probe in the midline in the suprapubic area, identify the sagittal section of the cervix, and then you need to fix the probe in the midline, tilting the probe from side to side. Then you put the color on. You can see the uterine artery, as you can see in this video, and then you freeze. You basically introduce a sampling gate of 2 millimeters to cover the whole vessel. Then you capture the waveform, as you can see in this video here. Once you have 3 consecutive waveforms that are similar, you freeze the image, then you trace the waveform to calculate the PI, and you need to ensure the peak systolic velocity is greater than 60 centimeters per second to ensure that this is indeed the uterine artery that you are sampling. And essentially, I go around the world educating people to measure this parameter, and I think I need to come to America. I will make it easy for you. Because everywhere that I've been to, after my teaching, everybody wakes up. It is so easy. I think we make something so easy complicated by making our lives complicated. So let me try and make it easy for you. It's very, very simple. And it takes less than 1 minute to do, and I can train an average O&G trainee to do that. So in terms of the remaining 2 biochemical markers, you can see the graphs on the right, the PAPA and PLGF, placental growth factor. These are markers of the placental function, and they have been found to be reduced at 12 weeks with a positive correlation with gestational age at birth for preeclampsia, meaning that the lower the value of these parameters, the higher the risk of developing early onset preeclampsia. As for the physical markers, you can see that the levels at 12 weeks are increased, and there's a negative correlation with gestational age at birth. So the higher the value, the higher the risk of preterm preeclampsia. So all these scatter plots, all these regression lines essentially lead to this table, which probably should be useful to people like all of you who would like to consider implementation of the screening model. So essentially, for the prediction of preterm preeclampsia less than 37 weeks, maternal risk factors, half the job done, 50%, fantastic. But obviously need to utilize the calculator that we have developed, not the NICE, not the task force approach, okay? And adding individual parameters from what we have obviously evaluated, and we can achieve as high as 66% with the measurement of placental growth factor. And obviously, having come from India, they cannot afford to do the biochemical marker, but they can easily introduce the measurements of blood pressure and neutral artery Doppler, so they can at least achieve 70% prediction. As for the triple test, I would say the Mercedes test, the best test available, is either with the addition of PAPE or placental growth factor. Depends on if you already introduced Down syndrome screening, whereby the PAPE is already free of charge. And as for if you want to really achieve the best prediction by introducing placental growth factor, we can achieve a detection rate of as high as 77% for preterm preeclampsia. I admit that we are not good at predicting late preeclampsia, but I think we need to do with one thing at a time. And for now, we can deal with preterm preeclampsia. And all of you might say, 77%, honestly, not good enough. So, but obviously, if you want to also focus on the very early onset preeclampsia with delivery before 34 weeks, our combined test with history, neutral artery Doppler, mean arterial pressure, PAPE and POGF achieves 90% detection for false positive rate of 10%. But another way of doing this is that we can opt for a different false positive rate. So we're not talking about Down syndrome here. We're talking about preeclampsia. We're not introducing a needle into someone's abdomen. We don't need to keep the false positive rate at 5%. We don't need to keep the false positive rate of 10%. But I would not recommend universal screening, but I will come back to that. You could consider shifting your false positive rate to 20%, achieving a detection rate of 85%, or even a 30% for 90%. So this is something that you, as a clinician or policymaker, will have to make a decision for. But we go with a 10% for 75% detection rate. It is not absolute, okay? So let's also go through a little bit of validation, because everybody would say, oh, it can only be done at King's, not anywhere else in the world. So through ASPRE, we were given the opportunity to validate this model prospectively across 5 countries in Europe: Spain, Belgium, Greece, Italy, and the UK. And then the graph on the right essentially represents an error plot of the detection rate based at a false positive rate of 10% using the retrospective data that we have collected to develop the prediction model. So for less than 34 weeks, 90%, less than 37 weeks, about 75%. Don't know why it's a little bit shifted. I think it's maybe the aspect of the slide. So it's been shifted up. I'm sorry about that. So for term preeclampsia, it's about 40 to 50%. So you will say, oh, these data are too good because we have fitted the model for the data that we have collected to develop the model. So through the prospective cohort study, whereby we recruited more than 8,000 women, confirming that 2.7% of cases of preeclampsia, you can see the purple error bars. So for early onset preeclampsia less than 34 weeks, we achieve 100% detection rate. As for preterm preeclampsia, 75%, and as for term preeclampsia, as we already know, is at about 45%. Not fantastic, and obviously that will be the area of research that we'll be focusing on in the next 5 to 10 years. So coming back, and you have already seen the slide from Mary. I'm just quoting 2 recommendations. NICE recommends that if a woman has 1 high-risk factor, or that she has 2 or more moderate risk factors, then she should be started on 75 milligrams aspirin from 12 weeks till the birth of the baby. And for American Congress, the recommendation is a lot simpler, and just 2 facts. So, but what they have failed to demonstrate to us is the performance. These recommendations have gathered information from epidemiological data, and to say that, yes, we need to screen for these risk factors. So this is the recommendation. And the 75 milligram aspirin, I think, again, is not really through the prospective evaluation of the history method of screening followed by aspirin prophylaxis. They did not do any of that. So we have taken the liberty to apply the screening approach in our population of 120,000 pregnant women, and the purple bar represents a NICE recommendation. At a false positive rate of 10%, we achieve a detection rate for preterm preeclampsia at 39%, as for term preeclampsia, 34%. And the American Congress recommendation is obviously much lower detection rate at 5% for preterm preeclampsia and 2% for term preeclampsia at a false positive rate of 0.2%. So, and now I've just put in our bars from the Fetal Medicine Foundation's algorithm. I think it's a no-brainer that we do far better with the combined test for the prediction of preterm preeclampsia, not so much for term preeclampsia, and I acknowledge the weakness of the prediction model, but nonetheless, we have done we have achieved effective prediction for preterm preeclampsia, yes, which is a more severe form of the condition, and yeah, we acknowledge that this is the minority of the cases, but I think the impact is far higher than those resulting from term preeclampsia. So moving on, the crux of this presentation is the prevention of the condition. And I think let's take a step back. Let's review the history of aspirin. In fact, the history of aspirin dated back in 1979, when Crandon and Isherwood observed that in nulliparous women that routinely took aspirin, and they found that there was a lower incidence of preeclampsia. And 6 years later, this group published in the Lancet the first landmark paper of aspirin. And this was a randomized study of 102 patients at high risk of preeclampsia and of fetal growth restriction. And then they randomized women into 150 milligrams aspirin versus no treatment. And two things we must remember: 150 milligrams of aspirin and 12 weeks. This is when they gave treatment. So the conclusion from this trial was that in group A, the treatment arm had no cases of preeclampsia, no cases of fetal death or severe growth restriction. And as for the no treatment arm, there were some cases of fetal growth restriction, fetal death or preeclampsia. So the conclusion from this aspirin study was that treatment in high-risk patients may protect against preeclampsia, fetal growth restriction and intrauterine death. But what happened afterwards? A lot of effort has gone into evaluating the efficacy of aspirin in the prevention of preeclampsia in more than 50 trials involving more than 30,000 women. You know, we wasted a lot of effort and money, and we wasted a lot of trust of these pregnant women who took part in the study. And the conclusion from this meta-analysis by ASCI, again published in the Lancet, was that a randomized trial of 31 randomized trial of 32,000 women, the conclusion was that aspirin could only reduce the relative risk of preeclampsia by 10%, and the reduction in preterm birth was also 10%. And obviously, at that point in 2007, I was halfway through my research. I was halfway through my thesis. I was totally disappointed. I was constantly criticized what was the point of screening, but obviously we did not despair. We persevered, but obviously we need to understand why we found relatively negative findings from this meta-analysis. 3 facts. One is the dosage of aspirin. And contrary to what the first trial used, majority of the studies actually used a dosage lower than 150 milligrams. And only 2 out of 21 trials used a dosage of 150 milligrams, as you can see in this bar chart. This is fact 1. Fact 2, timing of when aspirin should be started. Again, contrary to what the first study, did, from 12 weeks, you can see basically this line chart I plotted against gestational age at randomization. Only a minority of studies actually started aspirin from early pregnancy, and the majority started aspirin from whenever, basically, even as late as 30 weeks. And the third point is that 15 different definitions of preeclampsia were used across these 21 studies. So obviously, they meta-analyzed many very heterogeneous studies, so I'm not surprised that the study was not promising. So my life changed, 2010, and obviously I was seeing some light at the end of the tunnel when, bejeweled, clever man, a good friend of mine now, obviously. And so he found that by giving aspirin before 16 weeks of gestation, we could potentially reduce the risk by 50%, and even more so for severe preterm preeclampsia, more than 90%. Honestly, too good to be true, right? 90% reduction for preterm preeclampsia. There isn't one treatment in medicine that could reduce such, achieve such a good reduction, not even penicillin. But nonetheless, based on his work, these professional bodies have already recommended that aspirin should be started from 12 weeks given to high-risk women. But based on that, we have developed our trial, because some of you will call for a randomized trial because essentially the number of cases included in the subarm of women that received aspirin before 16 weeks was far lower than those that received aspirin after 16 weeks. So obviously, you might be happy with these results, some of you are not. So we had to do this randomized control trial prospectively. And again, coming back to the notion of giving aspirin universally to everybody, I think Mary has already addressed this beautifully. And based on this population-based cohort study in Italy, they compared 186,000 patients treated with aspirin to those that did not receive aspirin, and median follow-up 5 years. And they found that the aspirin arm had a 1.5-fold increase in the risk of major GI or cerebral bleeding. And coming back to that as well, I think universal aspirin management treatment, I think we will encounter problems in terms of side effects. Although through all the randomized trials, we have not seen an increased risk of side effects, major risk to the mother and the fetus. But certainly if you start giving every pregnant woman in this world aspirin, 150 milligrams, we will start seeing problems. One problem. Second problem, compliance. The compliance to multivitamins, guess how low or high it is? Less than 50%. And multivitamin is not even a drug. It is just something quite benign. You tell pregnant women they should take it, less than 50% of women will agree to it, let alone taking 150 milligrams of aspirin. So I don't think that's going to work. And those who are considered to be high risk by our screening method will for sure not take aspirin, because those who are going to be religious and taking aspirin are those who are affluent, eloquent, and of higher socioeconomic class. They are not the at-risk women. The low-risk women will follow your recommendation religiously, whereas the high-risk women needed to be told because they are from this lower socioeconomic class. They're not likely to be compliant, and I'll come back to this compliant issue later on in my slides. And lastly, if I were to give 1,000 pregnant women aspirin to prevent 3 cases of preterm preeclampsia, I'm subjecting 997 women aspirin unnecessarily, and I believe that is unethical. So coming back, why did the other trials fail? So we wanted to optimize everything in the aspirin trial, and so we did consider the timing of treating with aspirin, very important. And through this study by Ayala, they did this interesting study randomizing women into 6 different groups: placebo morning, afternoon, night, aspirin morning, afternoon, and night. And they wanted to see whether treatment with aspirin at any time point would improve the outcome of these women. And essentially, they have found that women being given aspirin at nighttime, there was a lower incidence of preeclampsia, fetal growth restriction, and gestational hypertension, and so forth. So this is why we have chosen to give aspirin at nighttime in our trial. And also the dosage, obviously, if you're still not convinced that 150 milligrams should be the dosage, then obviously you need to refer to this meta-analysis by Bujold. And essentially, they basically evaluated the dose response and according to the dosage for the development of preeclampsia and severe preeclampsia, and also dividing aspirin before 16 weeks and before 16 weeks. The conclusion is that aspirin, when given at less than 16 weeks, there was associated significant reduction in the prevalence of preeclampsia and with a significant dose-response relationship. And this is the study for the aspirin trial. We chose 150 milligrams, and I think I have convinced you why we have to use this dosage. And more importantly, also, we need to acknowledge that at a lower dosage, there is a higher rate of aspirin resistance. We recommend starting aspirin at 12 weeks. after Down syndrome screening, after preeclampsia screening, and also we consider stopping at 36 weeks because in a trial we wanted to avoid and minimize the risk to the neonates, and we recommended to give aspirin at nighttime based on the Ayala study. The outcome of interest was preterm preeclampsia, not term preeclampsia, not any preeclampsia. We decided to go for the more severe form of the condition. We could not go for early preeclampsia less than 34 weeks because if we were doing that, we would still be doing this trial in the next 5 years. So we had to be pragmatic. In terms of the study population, high-risk women defined by the Fetal Medicine Foundation algorithm. And we did this study across 6 countries, 13 sites, and the initial consort diagram, as you can see on the right, we wanted to screen at 12 weeks to identify 10% of high-risk women based on a risk cutoff of 1 in 100 or higher. We anticipated a lower uptake of 60% of women would agree to the trial because of aspirin being so widely available. We needed very committed women. We wanted to evaluate a reduction in the rate of preterm birth by 50%, so we needed to randomize 1,600 women to achieve 90% power. We did not go for a 90% reduction. I think that was too ambitious, so that's why we went for a conservative 50% reduction for preterm preeclampsia. And in terms of recruitment, we started recruitment in April 2014. We had to take a holiday for 1 year based on some issues with our drug supplier. So with that holiday, we did the validation study. So obviously, at hindsight, it was a blessing. We resumed the trial in July 2015, and it took us 9 months to randomize just over 1,700 women. And this is the consort, the actual consort and diagram. We screened 27,000 women, and then we identified 11% being high risk. We then excluded 332 women into the randomized trial for various reasons. As you can see, we had 2,600 women eligible for the trial, and in the end, 67% of women participated in the randomized trial. All in all, we had 798 women in the aspirin arm for analysis and 822 women in the placebo arm for analysis. On the right-hand side, as you can see, we recorded in terms of compliance with the trial drug, we had 80% of women taking more than 85% of tablets, and that was a level of compliance that we considered to be good. So these are the results, and the left-hand side is basically the Kaplan-Meier plot. Y-axis is cumulative incidence of preeclampsia, x-axis is gestational age at delivery, and the black line represents the placebo group, and the purple line represents the aspirin arm. And as you can see, it looks like that aspirin could reduce the rate of preeclampsia by half, and that translates into an 82% drop in the rate of early onset preeclampsia less than 34 weeks, 1.8% in the placebo arm versus 0.4% in the aspirin arm. And this is our primary outcome, a 62% reduction from 4.3% in the placebo arm to 1.6% in the aspirin arm, and a non-significant 5% reduction in the rate of term preeclampsia. We wanted to evaluate the effect of estimated risk and obstetric history in terms of the treatment effect size. So the top forest plot is showing the estimated risk. We divided risk into 3 groups, and essentially we have concluded that there are no significant difference in the treatment effect size between the 3 risk groups. As for past obstetric history, we divided women into nulliparous, pairs without preeclampsia, pairs with preeclampsia. Again, you might think that it only works for nulliparous women, but essentially we tested the interaction between these 3 lines and no significant difference between the 3, and you need to refer to the numbers, because in pairs women we had fewer women, but you can see there's dramatic non-significant 20% reduction in the rate of preterm preeclampsia in pairs women without preeclampsia, and a 50% reduction in those with a prior history of preeclampsia. And I mentioned the issue of compliance. Compliance is very important, and we made a huge effort in our trial to confirm that. And so taking any compliance, we could achieve a 62% reduction. And if we were not religious with ensuring that women were good with their tablets, we would have failed, because a compliance of less than 90% would achieve a non-significant 40% reduction in the rate of preterm preeclampsia. And we take compliance greater than 90%, we could even achieve a better reduction of 76%. So most importantly, we must educate our women of being compliant with the medication. And if they ask you, doctor, is there something I can do to help? Of course, they can be very compliant with the tablets. The second thing is any future trials should take into account compliance. Lastly, you ask me, is there a group of women that aspirin doesn't work? Sadly, there is, and that is chronic hypertension. Taking all data, we can see that women with chronic hypertension, aspirin does not work. And taking women who are religious with a tablet and without chronic hypertension, we can even achieve a bigger reduction of 95%. So this is a very important message. And as for secondary outcomes, sadly, I have not been able to demonstrate significance, but we need to acknowledge that we took a 99% confidence interval to account for the fact that we tested many, many outcomes. Statistically, we cannot stick with a 95% confidence interval, and therefore, we are not achieving significant outcome in the reduction of SGA with or without preeclampsia, stillbirth, abruption, and spontaneous preterm birth. But we must acknowledge the significant trend that you observed of reduction in SGA with or without preeclampsia before 34 weeks. This is based on small numbers, but with this, our statistician and trialists are in fact very reassured that we are most likely able to reduce the rate of SGA with or without preeclampsia. Lastly, perinatal mortality, morbidity. In terms of stillbirth, again, we did not demonstrate a significant reduction, but looking at the numbers, we had 8 cases in the aspirin arm versus 14 cases in the placebo arm. And as for neonatal morbidity, we took a composite outcome combining all of these. As you can see, we had 32 cases in the aspirin arm versus 48 cases in the placebo arm, achieving a non-significant 30% reduction in neonatal morbidity. And again, I would have achieved significance if I have kept 95% confidence interval. So side effects, you would ask me, risk is not increased. I'm sorry, the bottom is missing, but essentially we had a higher rate of serious adverse events in the placebo arm. I can show you offline. And as for side effects, the risk of bleeding is not high in the placebo arm, and this risk is not higher in the thinner women. And so you can be reassured that aspirin is safe, and the risk of side effects is not associated with body mass index, and in women identified as high risk by the combined test at a dose of 150 milligrams per night from 12 to 36 weeks of gestation, reduces the rate of preterm preeclampsia by 62% and early onset preeclampsia by 32%, irrespective of estimated risk and obstetric history. And I thank you for your attention. Thank you.